Hi, everyone. This is Eric Glazer, and welcome to Bright Spots in Healthcare, produced by Bright Spots Ventures. Our mission is simple: find what actually works in healthcare and help you all scale it. Each episode, I sit down with senior leaders from health plans, health systems, provider groups, and other innovators across the industry to cut through noise, share honest conversations, and unpack proven approaches delivering real results in the real world. This isn't a show for spectators or buzzwords. Really, it's for builders. It's for innovators. It's for the courageous, the ones not afraid to push progress inside their organization and beyond. If that's you, hit subscribe. You're home. This is your Bright Spots in Healthcare podcast. Greetings, everyone. Hello, this is Eric Glazer, and welcome back to Bright Spots in Healthcare. We are produced by Bright Spots Ventures. Our mission is to spotlight what is working in healthcare and help scale it. We bring leaders together across health plans and provider organizations and innovative solution organizations to share strategies that create real-world impact. I've had the privilege of doing this show for over 12 years now. I've gotten to talk to all kinds of leaders at healthcare organizations. I've realized two big social psycho dynamics. One, in healthcare, we love talking about our problems. However, the most interesting conversations are never about our problems, folks. It's always about the places where someone is already doing something successfully about said problem. And the number two dynamic I've learned is that very often the solutions that are working often take years and years and years to spread throughout our industry. They get pigeonholed in one location, one nook and cranny across this country. So that is the mission of this show, is to accelerate what's working across this country. And if you have not subscribed yet to the podcast and you're someone who believes you could truly make a change and how we all receive quality care in this country, and you're determined to do it wherever you sit at your organization, you should be subscribing to this podcast, because your peers are the ones that come on this show to share what they're doing, and they will provide you with ideas and tools, allow you to stand on their shoulders so that you could see farther and you can move faster. So take a moment, search for Bright Spots in Healthcare wherever you listen to podcasts. Find us, subscribe to us, find us on LinkedIn, Bright Spots in Healthcare. Follow us there. You will get all this great content. Doesn't come from me, just comes from the great leaders that our producers have curated to present in front of you. Because again, our mission is to bring the smartest in front of you to accelerate things that are working in this industry. All right. Our topic today is around rural healthcare delivery, because it forces organizations to solve problems differently. And if you're not at a rural organization, after meeting with these guests that I'm about to introduce you to, I'm telling you, you're going to get some unbelievably good ideas. Distance is greater in a rural setting. Workforce shortages are more acute, and the infrastructure that larger urban systems often rely on do not exist in the same way. But it's those constraints that have also driven some of the most interesting innovations happening in our industry. And that is why, although this is especially relevant if you're a rural organization, especially in Texas, but anywhere in this country, but even if you're not in a rural setting, you're going to learn something in the next 55 minutes or so. Across Texas, providers and health systems and rural hospitals are building new ways to extend clinical expertise, collaborate remotely, and reach and or support their patients who might otherwise fall outside the traditional care system or are receiving suboptimal care, or both. So today, we're going to explore what's actually working, what's still breaking, and what leaders are learning as they try to close rural gaps in real time. So if you think about cell phone coverage, in some places you have full bars. The calls are clear, the data is fast, and everything just works. But if you have Verizon Fios and you live in West Hartford, Connecticut, where my parents live, you lose your signal completely. And it's like you're camping out there. And it's not that your phone didn't work or stopped working. It's that the infrastructure around you has changed. And once that signal drops, everything becomes harder. The communication breaks down. My kids don't get to stream their favorite shows. Small issues become bigger problems. And what feels simple suddenly takes real effort. Healthcare faces the same challenges, and in many rural areas, it's not that the care doesn't really exist. It's that the infrastructure needed to reliably access it isn't always there. So, if access depends on infrastructure, then extending care isn't just about adding more services. It's about finding new ways, right? New ways to bring clinical expertise to where patients actually are and enable clinicians to receive the critical data they need to make better decisions for their patients. And that requires coordination across, right, the entire ecosystem, providers, health systems, tech partners, and community organizations. They're all playing a role. So that is exactly why TytoCare is supporting today's conversation. You don't see them on the show, but they're an important partner to Bright Spots of Healthcare. And if you haven't heard of them, they enable providers and health plans to deliver high quality remote care through its Home Smart Clinic. It's a platform, a really easy to use platform that allows patients or medical assistants or a nurse to perform a guided physical exam from the home or some remote location and then connect directly with an advanced provider or physician for real-time diagnosis of care. Think about what telemedicine is today and think about the next phase of telemedicine where clinicians could do virtually an in-person exam remotely through this one simple device. It combines diagnostic services with AI-powered guidance and engagement tools, and the goal is to extend clinical expertise beyond traditional care settings and the environments where patients actually go and live or go to work or go to school. So you can learn more about them at tytocare.com, tytocare.com. Thank me later. And thanks to TytoCare for supporting the show. All right, let's get going. Joining us today are leaders who are actively working to extend care across one of the most complex environments in the country, and each is going to share their perspectives from a different operational vantage point. So we're going to drop their bios into the chat, into the show notes, so we're not spending any more time reading long bios. They have incredible experience, all three of them. I'm going to introduce them very briefly, and then we're going to jump into our discussion. From Texas A&M and representing Aggies fans everywhere is Reyann Davis. She's the Director of Value-Based Care at the Rural and Community Health Institute over at Texas A&M. Reyann, welcome to Bright Spots. We also have Pothik Chatterjee. He is the Executive Director at Rice University and Houston Methodist Digital Health Institute and a return guest to Bright Spots. Welcome back, Pothik. And last, and certainly not least, is Dr. Indira Vadlamani, and she is the Division Medical Director for the Gulf Coast region at a little-known organization called HCA Houston Healthcare. So thank you all three for being here. I want to start today's discussion by grounding us in the reality, because rural access in Texas is very complex, and understanding the constraints is certainly critical before we talk about what's working. So I usually don't do this. I usually don't start with talking about problems. It's a big no-no for me, but I thought it was really important to get the context for today's conversation by spending 3 or 4 minutes talking about the reality in Texas and probably similarly in rural areas across this country. So Pothik, I'm going to put you on the stand first. Before we get into solutions, level set us. When you look at rural access across Texas today, what are, let's say, the top 3 constraints that matter most that every leader in this room right now needs to understand?
Thank you, Eric, for having me on this show. It's great to be back. So from Texas, this is a huge opportunity because Rural Health Transformation Program, this is a $50 billion once in a generational type of federal investment in rural Texas healthcare to expand access to care, address workforce shortages, and modernize health systems, including telehealth and technology, which is a big part of what our Digital Health Institute focuses on here in Houston with Houston Methodist Health System and Rice University. And Texas is receiving $1.4 billion over the next 5 years to stabilize rural hospitals and expand care. But the reality is pretty bleak right now. There's rural hospitals that are facing closure. They're cutting down essential some services that are higher cost, like maternal care, labor and delivery. Nearly 60% of rural hospitals are no longer delivering babies. And even though the $1.4 billion sounds like a big amount, when you look at the Texas population, it only comes down to $60 per rural patient. So it's not enough funding. The biggest challenges, I would say, if you put them in three categories, number one is digital access, so ensuring broadband connectivity in rural settings. Number two is transportation challenges and just the geographic distance in Texas. It can take 9 hours from Western Texas to get to Houston Methodist, to MD Anderson. And then the third is language. When we talk about telemedicine, we need to offer these services in Spanish, Vietnamese, Hindi, Bengali, the languages that are present in our Texas populations, both in urban and rural settings. Finally, we know that rural patients have higher incidences of cancer, heart disease, respiratory disease, according to NIH research. So there's a really strong need and significant challenges.
Really appreciate the landscape there. I see that our guests nodding their heads. Pothik, you shared with me a stunning example of the crisis in rural healthcare, specifically in Texas. Do you want to share that with the group around rural hospitals and labor and delivery? Just to give an example and an illustration.
Yeah, so as I mentioned, rural hospitals are having to cut some of their costliest services like L&D, and almost 60% of rural Texas hospitals are not delivering babies, leaving large spaces in our Texas state with families without a nearby place to give birth. So the hope is that this significant billion-dollar investment will allow rural hospitals to start reducing some of their costs through telemedicine, virtual care, connecting with the hub and spoke models of what we're innovative things we're doing here in Houston, and then allow them to be able to fund those basic services that are needed for families in Texas.
Perfect. So yeah, perfect layout of the landscape. And again, the constraints don't show up as concepts, but they show up as day-to-day operations, right? And so that's a perfect example. And so Reyann, you're in the field working with rural hospitals across Texas. Can you walk the audience through a specific example where a process looked like it was working on paper, but maybe it wasn't actually closing gaps, and how you zoomed in on it and reworked it into something that actually then started working and changed the dynamic?
Yes, absolutely. So I would say when it works, you're taking complexity and you're distilling it down to simplicity, and it's very intentional. So what we've seen across our work, we work with 40 rural hospitals and clinics, and we work alongside the Texas Organization of Rural and Community Hospitals, clinically integrated network in Texas. And its success doesn't come with adding complexity. It comes with operationalizing a few core things that work really well. So first, it has really been a team-based approach, not provider-dependent. If the model relies on the physician to do everything, it won't scale. What works is redistributing the work to care coordinators, handling outreach, preparation, and follow-up so that the providers can stay focused on clinical decision-making. And second, it has to be centralized and standardized. So rural clinics don't have the luxury of building everything from scratch. We've had success acting as central extension of the workforce, running outreach and tracking performance, and creating consistencies across sites. And it's really this hybrid model. So purely in-person work, purely in-person doesn't work, and purely virtual doesn't work. I think the model that really sticks in rural healthcare is a virtual first with intentional in-person touch points. So outreach, care coordination, and monitoring are done centrally, with clinics engaging where it matters the most. And I would say finally, there has to be clear accountability and measurement. When clinics can see the performance, like with our annual wellness visit rates moving from 8% to 50% in 9 months, that's what really creates buy-in and sustainability in the rural clinics.
Can you take us quickly through how you just mentioned that stat of decreasing care gaps
Mhm.
how did that happen? Like, could you just take me quickly through, like, wow, this is what we saw was happening, and then how you intervened and how that specifically worked to get there?
Yeah, absolutely. So what we saw was that wellness visits weren't happening consistently or not at all. And we created a repeatable playbook. And really that playbook was around a dedicated care team model. So we layered in a care team model that was virtual, but also patient clinic centered. So we have nurses, medical assistants, a centralized support system that's part of the clinic's workflow, but the clinic is actively also engaged in that workflow. They're on boots on the ground. So this centralized outreach engine created processes where we could do outbound calling. We engage the patient at scale, removing the burdens from the clinics. And then we did pre-visit preparation. So doing a lot of the pre-visit work for the clinics sets them up for success when the patient comes in for that visit. So we were looking at chart gap, gap identification, and looking at the risk awareness before the patient even walks into the clinic, and then embedded best practice workflows in the clinic with training. So we just don't do the work. We train the rural clinic staff to work alongside us in these models. And then lastly, again, just ending on that performance and tracking, it's very key to track your performance, and then we continually refine workflows because every clinic setting is different. Every organization, every rural community is different. And so, yes, you have this broad playbook, but you have to refine it based on the geographic regions and the resources they have.
Okay, I'm going to repeat some of this back. Incidentally, one of the things we started doing based upon your feedback, everyone, is for those watching live via Zoom, we're trying to capture some of the highlights, almost like live tweeting in the chat. And so we did that because some people asked for it. And we get that feedback from you through a survey we put in the chat and we sent to you by email at about 45 minutes past the hour. We'd love for you guys to complete that. It takes 5 minutes and allows us to enhance things. So I'd like to know, now that we're doing these live tweets on chat, are they helping you? Is it a better experience for you? Like, we want that feedback back. And if you have any new ideas, we want to hear about it. So what I heard from you, Reyann, is you created this, you saw that the wellness visits weren't achieving nearly what they were supposed to, largely because the clinics were overburdened and under-resourced and overwhelmed. You created a centralized support system that supported multiple clinics and integrated the centralized support system into the workflow of the clinic, which is super important. We won't double click on how that was done. That's my whole other conversation. But here are the key things, just so everyone listening, that I heard you say that this support system did. Outbound calling that allowed engagement at scale. This removed a huge burden off the clinics. Please interrupt me if I'm catching anything wrong. They also worked on pre-visit prep, which I think is super important. So before the visit, getting the members whatever information they had, HRA, whatever they had to fill out, and any kind of prep that they had to have, an education they had to have. And then tracking, which, right, you can't manage what you don't measure. And then understanding that those failures is feedback. So you see what's not optimal and refining it. So it creates almost a TQM, I feel, come back in business school kind of process here. Some of the highlights of how this centralized support system is working so well.
Absolutely. You got that correct.
Awesome. All right. That's the view on the ground, folks. Let's zoom out to a larger system now, because those same challenges start to show up in different ways. And let's go back to Houston. This time we're going to talk to Dr. Indira Vadlamani. She, again, is at HCA, Houston Healthcare. So, Dr. V, from your vantage point, with a large system like HCA, where do you see the access challenges showing up most acutely in day-to-day care delivery, and how are you guys on the clinical side working to deliver better care to these remote patients?
So I also agree with what our speakers have talked about so far. Are you able to hear me, Eric?
Yeah, sound great.
Okay. So there is significant workforce shortages in the rural communities, as pointed out by Mr. Chatterjee and Reyann. Both have said the same thing. Low number of endocrinologists or specialists, oncologists, and just primary care as well. I am a pathologist, and I can also say that there is a significant shortage in pathologists. I guess whoever is settled in the community is practicing, and there's no young talent, so to speak. And young talent is what drives your medical field forward. So with that kind of makes you understand the staffing shortages we have in rural settings. What we did in HCA is basically amongst the pathologists itself, to simplify the whole thing, we created a group of consensus group. And this consensus group actually connects us, the pathologists over here in Houston, distributed in about 13 hospitals in this area, to two of our small South Texas hospitals, which are in our remote rural setting. These doctors down in the rural setting are able to consult with us in real time, either by sharing their patient history and images, or even live streaming what they're seeing. So this kind of creates not just a collegial, warm, closer work environment, that it develops a team, it develops togetherness, and also provides consultation that is up to date. And I think decreases the shortage that we see with lack of specialty care. And to expand on that, I pretty much have, in the beginning, when we started down in South Texas, the breast radiologist down there was very unhappy with the lack of the diagnosis or correlation with what they were seeing. And with this consensus group, where they're able to share their breast cases in real time, we kind of completely eliminated that complaint, 0% gone. So that's one way of getting around it. But that is just a beginning, and there's more to be done, obviously.
Yeah, it's super, super smart. I've seen an analogous one here in Massachusetts, certainly not as rural as Texas, with hospitals on the shore in the Cape connecting with Mass General and Brigham in this way. And I think it's super important that what you're doing is taking the expertise of the teaching hospital with deep specialists and subspecialists and extending their input and providing scale to your not even sister, with your
Yes.
more rural community hospitals across the state. I love to hear that working. We'll come back to some things around that in a little bit. Okay, folks, we've talked about constraints, and now we've talked about some of the things it takes to make things function. I want to shift what it looks like when a system actually is building operative initiatives around those realities. So Pothik Chatterjee, again, over at Rice University and Houston Methodist, can you walk us through now an example of how you guys have actually built a model to extend care beyond the traditional settings and what it took really to make all of that work?
Yeah, I talked about the stark challenges initially, but now I'll share some bright spots in healthcare that can help solve some of these urban-rural connectivity and medical expertise challenges. So I'll share 3 examples quickly, and we can go into details as you like. The first is the Houston Methodist Virtual ICU, which we built in March 2020. And it was incredibly helpful during the pandemic because it decreased the number of interactions that our nursing staff in the ICU needed to interact with patients. So the virtual ICU has now been live for 6+ years, and it provides continuous intensivist coverage for 300+ ICU beds. And we have software developed by a local Houston company called Medical Informatics that calculates each patient's stability or risk of deterioration. So it allows the clinical team to anticipate events and act quickly. Each of our ICU rooms are equipped with a virtual alert button so that the bedside team can immediately alert the remote intensivist and nurses. And what are the results from this program so far? we have seen an increase in safety, in patient safety and operational efficiency, including a 37% decrease in codes, specifically code blue events, which are critical medical emergency events. The second bright spot has been the use of wearables in our inpatient setting. So we have been using a coin-sized, FDA-cleared adhesive wearable device to continuously monitor patients' vital signs in real times. This is now at scale, deployed over 2,600 non-ICU beds and home-to-hospital programs. And I see a lot of opportunity for this in rural patient monitoring. This coin-sized device collects up to 1,440 sets of vital signs daily, acting as a virtual nurse to supplement in-person care. And we just released some results in early 2026 from our wearables, our BioButton devices, and found that continuous monitoring has reduced relative mortality risk by 27% by identifying deterioration at more treatable stages. So the key takeaway is earlier detection translates to better outcomes and shorter hospital stays and improved survival after ICU transfer. The third bright spot is in AI, which is the biggest hot topic of the moment. We're using AI for both ambient scribing, which has increasingly become table stakes in urban settings, and hopefully we'll be seeing expansion in rural settings as well. This ambient scribing technology has transformed the experience of our clinicians by reducing pajama time. Particularly in the emergency department, clinicians have to put in 4,000 mouse clicks on average during a busy shift, which is just terrible. I mean, it takes away time from their patients, face-to-face interactions, really listening to what the patients are telling them. And so we've already now implemented ambient listening with 500 Houston Methodist doctors and in an outpatient setting. Now, the next challenge is doing this in a high acuity care environment, which has some of the most complex nonlinear care pathways. But we are seeing results already with provider satisfaction. Our providers found that 90% of ambient listening users are able to better focus on patients, and 92% said it saves time in charting, and 86% cited improved work-life balance. We're also using AI in our operating rooms and turning them into smart rooms. So we're using AI cameras to improve our turnover of surgery ORs, which has a huge financial impact, provider satisfaction, and patient care and satisfaction improvement as well. So we started this with a third-party vendor as a 36-room pilot, and we have now scaled it to 200 plus operating rooms and clinical spaces. The results have been a 15% increase in surgical volume without adding new staff. And that's primarily because what we call in our industry, the paperwork tax was digitally automated. So the tax went away and the efficiency improved.
Wow. There was a lot there. I want to try to summarize it. You're going to need your help, Pothik. So I'm going to go backwards and you'll help me with the earlier ones. So first of all, we have the virtual ICU. Key things there were it's AI-enabled cameras is the key to making all that work. So that's a pretty sexy, if I may say, way of and sort of innovating necessities, the mother of innovation here. The second is, ambient AI and scribing is innovative. It's not almost everyone's doing it now, but certainly it's evolving how we practice medicine, not just telemedicine, but all medicine. And the pilot expanded there too. So those were two things I heard. Remind me the one.
These are BioButton wearables, which are being placed on patients for continuous monitoring, and reducing code blues is one of the results that we have seen so far.
And then what was the first one?
The virtual ICU. So virtual ICU, the BioButton wearables, and then AI we're using for both ambient scribing and AI cameras for smart rooms.
Okay, I knew there was four. I kind of broke up the two AI things. Perfect. That was super great. It's really important point, and I just want to, because you're describing not just virtual care, but you're describing how just virtual care is evolving and becoming ubiquitous, and it's how access gets extended. It's super important. An example that comes to mind that I want to talk to folks about very quickly here is a school-based virtual program. I mentioned in the beginning, if you were joined late, our partner supporting today's show is Chatterjee. They're not on the show, but they're a big supporter of Bright Spots in Healthcare. And they've been working with organizations like Avo eCare, who's a telemedicine provider in Sioux Falls, South Dakota. Not Texas, but similar rural environment. And that model extends care into the community in very practical ways, not entirely different from how Pothik was describing things. What they're doing is equipping schools with a connected diagnostic tool and linking them to remote clinicians so students can receive real-time, deep medical evaluations without ever leaving campus. And that means fewer missed school days, less strain on the school nurses, and faster access to clinical care, especially in these underserved communities where options are very limited. So in Avo eCare's implementation, the model reduced ED department visits, unnecessary ones, by 10%, over 10%, in fact, and that kept students in the school and connected. So there's a whole case study that outlines how this got kind of landed and how it got implemented with more than 130 schools and 100,000 visits. It's an amazing story. If you want a copy of the case study and it talks about specifics on how they executed this, happy to send it to you. And incidentally, I know Tito, like I said, isn't on the show today, but if you wanted to be introduced to one of their experts for a consultant, how a remote device like this can take your organization to the next level of telemedicine, happy to set up that call. It would be more of a consulting call, not so much a sales call. You could come with questions that could be relevant to your business and not necessarily tied to adopting the Chatterjee solution. I'm happy to make that introduction to you. So I'll put up a poll there. And if you want to meet Chatterjee or get a copy of this case study or both, just let us know and we'll make all of that happen and reduce the friction there. So thanks for all of that, Pothik. Reyann, I want to come back to I want to come back and make sure I'm not making sure you're not being redundant, but the example around the wellness visits, and once you saw that gaps, what did you actually need to change? And if you thought there were any things that made this, you mentioned the repeatable process, there's anything specific that you needed to do to make that process repeatable and thus scalable, so people listening can continue writing notes and have that playbook locked in?
Yeah, thank you. And I think the theme around workforce shortages and healthcare being an access issue in rural communities, it really leans to all of the discussion today and what we've brought in. And I love the discussion that Dr. B said, togetherness. And really that's our approach. And that's what we hear across the state is that togetherness approach. So how do you, we're creating these care teams with the clinic so that we are educating them alongside our best practice work. I think one of the key pieces that we find is that you do have to tailor it to the rural communities. It's not a one size fits all in the industry, and it's dependent on the resources of those rural communities and what providers they have available. As we think about these innovative approaches and as we've rolled out our best practices, you have to be nimble and willing to navigate new initiatives differently to get the outcomes you're looking for.
Got it. Did I cut you off? Are you good?
Yep.
Okay, great. I'm going to come now back to Dr. V. When you start thinking about how virtual care is actually being used inside HCA, where are you seeing it make meaningful differences of how care is being delivered and how providers are able to interact with each other beyond the example you gave us earlier?
Certainly. We actually use, just like Zoom, we have WebEx. And on this WebEx, the multiple departments, that is the surgeons, radiologists, radiation oncologists, our care nurse navigators, and along with the scheduling nurses. Everybody is a part of this WebEx, and we discuss the patient care in these multidisciplinary tumor boards. Now, usually, historically, the multidisciplinary tumor board used to be in a single room where all the doctors sat together and discussed the patient care. By no means there's a HIPAA violation here, because we are all care team that are taking care of this patient, and WebEx is an intra group for HCA. It's not something that is outside. It's all encrypted. And we don't take patient names. However, so the surgeon actually starts with the history on the patient, and then we go on to discuss the images. Now, keep in mind, these doctors are all geographically scattered and not in a single town or a single room. And this has worked with our South Texas hospitals as well. And this is how I actually have the breast concordance going for the breast patients down in South Texas in a rural setting. So this also helps the real-time collaboration for the patient care, and the nurse navigator pitches in about restraints for the patient in terms of socioeconomic status, or if they're able to access or are able to come for surgery, and arrange for transportation for the patient. So these discussions and the WebEx groups kind of take away the geographic constraints. Now we're talking about hospitals that are 6 hours away, and we're able to consult on these patients with each other in real time. Now, the only thing that would limit is lack of internet, because obviously, as Mr. Chatterjee mentioned, we need broad-based connection and live connections going. If there's none, then that is not possible. So in addition to consulting within the multidisciplinary virtual tumor conferences, we also have real-time collaboration between the pathologists within the entire state, North Texas, Houston, and South Texas. And not just that, we also have HCA GI groups, HCA dermatopathology groups, and multiple specialties correlating. In other words, expert consensus from within multiple states in the US. So that kind of helps and takes away the limitations of not having access to expert care. And last but not least, I guess labs can also be interpreted remotely once they're loaded in. But as Mr. Reyann pointed out, the lab first needs to be drawn, which can be accomplished by our nurse practitioners or registered nurses even. And that could be interpreted across anywhere with any complications dealt with immediately.
There's a question submitted from one of our attendees prior when they registered. I'll throw it in here. And why don't I let you go first, Dr. V, and if Reyann or Pothik, you want to jump in on top of it, just jump in. But are organizations kind of utilizing, is it comes to gaps in care or just overall clinical quality? Are you using home self-collect lab tests, or are you sending paramedics or CHWs into the home? Like, how are you collecting labs?
Reyann, you can take that. I mean, you kind of addressed that earlier, so.
Yeah, I'm happy to jump in. So we see a lot of rural communities where they have house call programs or home visit programs. So a lot of the clinics we work with are already have established advanced practitioners going out to the homes, not only to collect specimens, but also perform visits and work with these really high risk chronic patients in their home. And it also gives insights into other factors, environmental, social factors of that patient's care. We also see several communities that are starting to deploy mobile integrated health, which would also include community paramedicine and other support systems within the community that will make those those home visits.
Yeah, I wanted to go there with that, so I'm smiling. Before I do want to ask you a follow-up because I heard advanced providers, but that doesn't feel very scalable to me. So you're saying beyond just a phlebotomist, who someone could draw the sample or collect the sample, you're bringing advanced providers, and is that something that's common? Because I'm hearing a lot of things around resource restriction, restraints and staffing and all that. You're able to put advanced providers in the field at scale.
Yes, we do have organizations doing APPs, but they're doing more than just drawing labs. They're doing visits, right? So that those use cases are more of a visit approach, holistic approach. Whereas we do have communities deploying certain resources just for like particularly drawing labs.
Got it. I'm going to ask you a quick follow-up. Oh, go ahead. Did you want to say something, Dr. B?
No, that's it. And then once those come back to the hospital and load it on the machines, the results of the patient will be out for interpretation. So that's basically it. Yes.
There's a comment I can make because in my past life, I worked many years at a company called Best Doctors that got acquired by Teladoc, and we were all comprehensive second opinions that well beyond the stereotype of what a second opinion is, and a lot of the diagnostic accuracies that issues that organizations and markets face are tied to film reading, both on the radiology and pathology side. And what I would say, and what's really smart about what you're hearing from HCA is we're all human beings. And I know AI is here maybe to save the day in this, but like we're all human beings and repetition matters. And so what we found clearly was, pathology labs that just looked at cancer and certain kinds of cancers were more accurate. It's just human nature, right? So when you're when you're trying to provide scale to these community-based hospitals in rural areas, you're just going to have the reps that a city hospital, teaching hospital at HCA has. So it's only going to improve the quality of care. Okay, let's do this. First of all, we may have a time to grab a couple more questions from the audience. I just did that daringly. You could use the Q&A module, folks, if you want to. Feedback on how we're providing this experience and the information. I'd love you to provide that for us. In 4 minutes, you'll get another email from me with SurveyMonkey, but Jess is going to put the link to the survey in the chat. 3 to 4 minutes to complete. It's mostly multiple choice. And we look at all of them and we're trying to enhance the experience through every data point we get from each one of you. Pothik opened up the door on RPM a little bit with the blue button. You just alluded to it, Reyann. So I'm going to combine 2 questions I had prepared for you because I'd love you to talk around how teams get stuck early with like RPM and anything to do with chronic care management, and how you help hospitals moving from planning to actually implementing something that works. And then because you opened the door on it, I'd also like you to talk about, as sort of a follow-up, how you're thinking about getting into combining the RPMs with people in the home, and maybe expand a little bit about what you're doing with paramedicine and some of the other things you're doing with community-based organizations.
Yeah, happy to. So like what you kind of alluded to is most organizations, rural organizations, will get stuck because they don't know where to start and they think it's too big, or they overanalyze even like the return on investment, specifically when you think about chronic care management and remote patient monitoring. So what we advise is that they trust that the CCM and RPM bring value to their patients, but let's start with what you already have and layer from there. So let's start with the resources you have and start small. And then as you grow the program, you're going to start to see those dollars come in, and then you can continue to grow upon that. So it's building a foundation of the core team, care coordination and outreach, that's needed to reach patients through CCM and RPM. And then identifying which patients you're going to target. Usually your high-risk chronically ill patients. And thirdly, leveraging, again, that hybrid model. Rural hospitals don't have a lot of volume sometimes, for a full FTE to support chronic care management and remote patient monitoring. So we've helped them think about shared or centralized resources. I want to give one example. We have a great bright spot in West Texas, independent, 3 different rural hospitals and clinics. They're working together in a regional model to do chronic care management and remote patient monitoring. So they've collaborated and created a regional approach where they've shared the FTEs and the resources, and they've employed these teams in their communities to do chronic care management. So the patients do have that local connection with the care team providing the services. And more importantly, so we provide the expert consulting to help the rural groups get up and going, and then align everything lastly with the revenue and incentives so that they're getting those dollars in and can continually build upon their base foundation.
Before I follow up with the paramedics, I'm actually going to put in that for a second. I want to double click on some things and maybe even ask Pothik to come in because I have a follow up for him too. So I heard 3 things that you're doing, strategies almost. One is crawl. My words, not yours. Crawl, walk, run. So start with what's working and then expand it. Can you let us know when you're thinking about crawl, walk, and run? Again, I know I'm putting words in your mouth, and you're starting with what's working and you're determining when to stand it. What are the stage gates, or just an example of a stage gate to decide, okay, we're ready to start walking now. We're ready to start running now. And how to execute on that a little bit.
Well, I think with CCM and RPM, when you think of the programs, you're trying to get more patients engaged and continuously enrolled in your program and month to month to month, so they're not dropping off. So I think the crawl is, let's start with a goal of 20 patients to get on CCM and RPM, set a target goal. And then once you meet that goal, that's when you can start ramping up. You understand what it takes to really engage with that smaller volume. And then walk by then creating processes that are throughout your workflow within the clinic. So if the patient's coming in for their annual wellness visit, or if they're a high ER utilizer, let's target those patients. They really do need the help and they're going to want to be part of these types of programs. And then that just opens the floodgates. That opens the doors for even more patient volume into these programs. And I think that's when you start to run, where you're getting those high risk patients and they're engaged. And now you need more support. You need more FTEs to support the patient population you have. So hopefully that answers your question.
It does. I have one more follow-up. I hate to keep you on the hot seat here. So I think number 2, your third strategy was shared resources, and you shared the example of 3 rural hospitals pooling their resources. That's awesome. I'm going to go with number 2 though. You said target. Tell me if I got this right. Target the higher cost complex patients, right? So
yes.
So that doesn't. So I just want to make sure you could rectify for this in my mind, in case any of our audience is thinking about it the same way. Crawl, walk, run, but starting with the higher complex patients is a little bit, conflicting. And so sometimes the complex, and I wonder how much work you guys do in determining who's most likely to engage, like who could we win with? There's no low-lying fruit, but the lowest of the lying fruit, who could we win with before we start going after who is going to be much harder to get on course and engage with us?
I'm glad you asked that question and for more clarification, because I think what we see is when you have a team that's doing this, that is familiar with the patients already, that clinic team knows which patients are going to be ideal and a good fit for chronic care management and will be engaged. So that initial population, when we start to talk to clinics about implementing a program like this, they're already thinking of patients that are coming into their doors that are actually creating inefficiencies probably in their workflows because they're needing more hands-on, more touches. So those are typically your higher risk patients, but it could be a combination of not as high risk versus just more of like, I guess, assumptions, because there's a lot of inefficiencies they're building into the system because they do need that high touch point.
Yep. Perfect. All right. So I'm going to land the plane here in the last 11 minutes or help land the plane here. You guys are going to land the plane. I'm going to come back to see if we have time to hit the paramedicine question again. I know we've been teasing that for a bit, but I want to bring in Pothik. And Pothik, I'm going to combine two questions for you because you'd already brought up the bio buttons, but I do want you to expand upon what remote devices are doing for you guys. If there's anything that you could expand upon and how you guys are leveraging remote patient monitoring and extending what's becoming more sophisticated data collecting tools that clinicians need in your sort of hub and spoke model. And then I'm going to ask you a follow-up question about innovation and AI. So go ahead.
So wearable devices are one of the key pillars of our research at the Digital Health Institute. So Rice engineers, professors, and postdoc students are working hard every day in their labs to develop new sensors that can track multiple sources of data from patients so we can use that for multimodal AI research, prediction, and early detection of disease. So some examples that I see are the just tremendous evolution of wearables. They're now actually medical grade biosensors that can act as early warning systems. So we have smart rings like Aura, bio patches, and even smart clothing that can now monitor things like continuous glucose, blood pressure, and ECG with wearable patches. So you don't need these huge machines anymore that cost millions of dollars. You can put ECG wearable patches on patients in a telemedicine RPM type of visit, and the costs are starting to come down as well. So these devices can detect signs of a heart attack, stroke, or infection, like a sudden spike in skin temperature or a drop in heart rate variability, days before the patient might even feel symptoms.
So
It's really
a day where you're like $60 per patient as far as the rural health transformation bill and all that. How are you? Is this for the future, or are these the ECG biopatch?
These are available today, yeah. So in some cases, they're still going through the FDA approval process, but the technology is already available and the clinical use cases are being developed right now in real time. And what's great is that these different devices can actually communicate with each other as well in closed loop systems. So for chronic conditions like diabetes, wearables can now talk directly with insulin pumps or medication dispensers so that they can adjust dosages automatically based on real-time data. We already talked about the need for high-speed infrastructure, 5G connectivity, and medical IoT. You can see why that becomes so important when you have a number of devices communicating with each other, turning smart homes into smart hospitals of the future at home. What we're also seeing is lots of innovation with virtual reality and extended reality. So telemedicine is no longer just talking to your doctor. Patients can use VR headsets to actually enter a virtual environment where they can perform guided rehab exercises with AI tracking their form and range of motion more accurately than a human eye. So let's say a patient had a stroke. We are doing studies and clinical trials with devices and sensors to track the patient's movements and rehabilitation journey. I also see a lot of opportunity with mental health using digital therapeutics and immersive virtual reality environments for exposure therapies, treating phobias or PTSD, and guided meditation in ways that a standard video call cannot.
I love it. I love it. We could do a whole session on the future, according to Pothik. I think it's super. I'm so jazzed by every time I hear you talk about things like this. Do you want to expand upon very quickly how you're thinking about algorithms and AI agents? Could we do that in a couple minutes before we close up with that?
So AI agents are a big focus for both research and implementation. But I would say we're still in the early stages here at Houston Methodist. We're still at the research phase to determine what type of autonomous tasks these agents can do, whether it's improving clinical workflows, improving patient referrals and triage, or more on the back end, like revenue cycle management, payer-provider interactions, trying to improve prior auth? That's where I see most of the value right now. Some of the clinical value is still hypothetical.
Got it. All right. So if that's, I'm not going to call that running because I think that's really walking at this point. It's not crawling, folks, but I just definitely think it's in walking. I think it's happening today. And if your organization thinks it's way out in the future, I think you're not seeing how fast we're all moving here, and there's a chance to really innovate. I'm just really just listening to the three of you. I'm just so hopeful for our future, especially around rural care. In the spirit of like crawling and maybe walking slowly, Reyann, there are obviously some traditional or kind of used to be new. Now they're becoming traditional models that you're saying. We've alluded to them with paramedicine, virtual primary care, integrated behavioral health, working with CBOs and community-based extensions. Can you talk a little bit about how you guys are doing that right now and how effective that is in rural Texas?
Yeah, we are seeing more and more rural communities adopt this mobile integrated health kind of system, whether that is community-based extensions like paramedicine. We have a group in North Texas who won national awards around their mobile integrated health approach, incorporating community paramedicine into the work. So not only following patients post-discharge, but looking at your frequent ER utilizers and those with significant social determinants of health. They've had great outcomes, meeting the needs of their community. And it's great to see their case study because they've also incorporated this. It's not siloed. Their mobile integrated approach is across their primary care clinic enterprise. So when they have chronic care management, when they do wellness visits, they're plugging those patients in with the resources they need through these vehicles. And there's other mobile experiences and examples where you have mobile clinics going. You mentioned the schools. We see that across the state too, where there's mobile vans going to schools to help with those patients those kids that need care. And then integrated behavioral health. We're starting to see that behavioral health piece is one of the biggest gaps in rural healthcare. So embedding that within primary care through collaborative care models, and those are billable models. So it makes you're getting funding for the resources once you can get those programs up and going and aligned with their overall approach. And I think the last thing I'd end on is for rural healthcare. I think across Texas and other states, you're really seeing them centralize service models through like clinically integrated networks or managed service organizations. So they still remain independent, but they're sharing their resources and sharing the infrastructure that is not there.
Yeah, I love that. And I see the surveys coming in already. If you guys want us to talk about those collaborations in more detail on a future show, let us know. I think those are really interesting, and peer-to-peer collaborations, even amongst organizations, are certainly one of my favorite topics. They're hard to do, easy to talk about. Could you just comment real quick? Question from one of our audience members. You alluded to the billable stuff and thus alluded to CMS. Even though you didn't say it, how are the federal changes impacting clinical services and quality reporting in the near future?
So for rural healthcare and federally qualified centers, so they do not have the same billable standards as just your other normal clinics. And RHCs and FQHCs and CMS, they've have really, in the last couple of years, moved billable services into their space where they can get revenue for all the services they're already providing. FQHCs and RHCs provide a lot of community-based care outside of their four walls, but now they can bill for it, which is great because that helps them continue that care even when there is a shortage in access. I think quality reporting for rural health clinics is a challenge. There is oversight that, hey, we're going to reduce the administrative burden, but we're going to electronic clinical quality measures. However, there's not the infrastructure to support those electronic clinical quality measures in a rural healthcare space. They're not on the bells and whistles of all the analytics and EMR tools that others might have. I tried to end with a bright spot, but there's the challenges from there too.
By the way, our guests do get royalties for every time they mention bright spots. You could hear that in the flow. Great job, everyone. You did great.
I mentioned another optimistic area for federal policy and reimbursement, which is the CMS Access Program, which looks at remote patient monitoring and treats the payments in a new way. So now they're taking an outcome aligned payment model, similar to population health models or value-based care. So based on the outcomes for patients, Medicare is going to provide additional reimbursement for the CMS Access Program. And they're focused on 4 chronic conditions: early cardio-kidney metabolic, musculoskeleton, and behavioral health. So this represents a huge funding opportunity for the organizations that take part in this 10-year voluntary model.
Perfect. Great final comment. I appreciate it. Thank you to all 3 of you for the work you did to prepare for this and what was a super engaging conversation. I think what you made clear is, improving access is not just about adding more care. It's just about strengthening the systems that make care reachable in the first place. And you guys are all doing exactly that. So thank you for everything, for doing this. For all of you who took the time to join us today, thank you. If you're attending live, we are going to send you a key insight summary of the highlights of today's show, so you have that. It's sometimes hard to take notes and grab everything. So in case you're not as good a note takers as us, we're going to send you that. If you're listening and you want to request that, you could simply email me to eric.glazer@brightspotsventures.com. Thank you all for spending that hour with us. We do not take the time you spend with us for granted. We know you're super busy. Shout out to Jessica Tenzer for producing the show, bringing all these great leaders together. We produce this show for you folks. Thanks for attending. This is your Bright Spots in Healthcare podcast.